housekeeping items, and then we will go ahead and get started. If you could please keep your lines muted and your cameras off if you're not a speaker. That way we don't have any disruptions. And if you have any questions throughout the training, please ask those in the chat box, and our speakers will get to those when they are able to. For our preventative health program, our next training will be on adolescent vaping on August 25th at 12 p.m. And you can register using the link there. We also have new resources available on our website. This training will be, the slides will be available afterwards as well. And the CME survey will be sent out tomorrow to receive your certificate and credit for attending. There's one CME and one MOC Part 2 credit available for attending this training. This is a list of all of our webinars that we have. We would love for you all to sign up and join. Our quality improvement project will kick off in December. It is a 9-month quality improvement project. We have free resources, action period calls with content experts, and you will be able to choose your screening tools that you will measure. So if you're interested in the project, please feel free to reach out to me. This is for primary care providers. And at the end of this, like I said, there will be a post-survey evaluation, and you can complete that, and please include any constructive feedback. There will also be a 90-day action plan that you will complete, and we'll follow up with that in 90 days. And the speakers have no disclosures. And I will go ahead and pass it off to the speakers. Thank you all for being here today. And thank you again to Ohio Department of Health for their support.
And thank you, Alex. Can you hear me, for all of the technical support and for getting us all here today. We are, the 4 of us presenting today are the AAP chapter breastfeeding coordinators for Ohio. And we have a broad range of clinical experience and breastfeeding experience. So we hope that we have something for everybody who's joining us today. You can put questions in the chat, and our contact information will be at the end if there are any discussions that would benefit from continuing at the end. So we are very pleased that August is the U.S. National Breastfeeding Month in the U.S., and the first week is the World Breastfeeding Week. With the goals
to go to the beach. What are they doing?
Step up, educate,
Yeah,
and
I have to
support.
agree. You'll be down there? Oh, okay.
We're going to start today with the U.S. Breastfeeding Committee here. This is their homepage. It is a coalition of over 100 health professional organizations and associations, such as the AAP, AAFP, and ACOG, that collaborates to provide breastfeeding support through policy and practice. And full details for the remainder of the celebrations this month are there, with opportunities to connect, honor, and support our breastfeeding families. As well, there are educational materials and social media kits that can be used in your own practices and institutions. The next slide. We are also pleased today to be able to promote the newly released AAP policy statement on the use of human milk. You've probably heard some of the highlights of this statement through the national media already. But this provides guidelines for providers, recognizing the imperative to human health for the provision of human milk for our newborns. It provides a really nice review of the short and long-term health benefits conveyed, and the recommendations now match the World Health Organization in terms of exclusive breastfeeding through 6 months, with addition of complementary foods and continuation through 2 years or longer. Now, further in this guideline is the recognition of the opportunity and responsibility that we have as pediatric providers to observe health outcomes within our own systems, to analyze the systems that are producing these outcomes, and to improve the variables as possible within our scope of practice. The next slide. The CDC has a great initial landing page to portray the current situation. So breastfeeding data is collected through the National Immunization Survey and reported yearly. On my left-hand side here is the map of the US, with darker being lower breastfeeding initiation rates and lighter colors being higher. On the right-hand side there, though, is the percentage of breastfeeding initiation by year of birth, and this is 2019 data. And that number for any breastfeeding is about 84%. And then you can see 6 months and 12 months for any breastfeeding. And then the next chart over looks at exclusive breastfeeding at 3 and 6 months. And those numbers are about 45% and 25%. And I think it's worth noticing that over the past 10 years, there has not been a significant change in these numbers. Next slide. The CDC also provides national data on race and ethnicity, and gives us a starting place as we are understanding and implementing strategies to target disparities which are systemic, unnecessary, and avoidable. The next page. So a resource that I've found quite helpful, and that is on the right-hand side of your screen, is ODH health improvement zones by county, and a social variable index has been, social vulnerability index has been calculated, which is defined by the demographic and socioeconomic factors that affect health resilience. And when we compare that with the darker boxes being higher social vulnerability to the breastfeeding initiation map on the left, we see that there is a fair amount of overlap in these factors. Opportunity and support for breastfeeding affecting resilience. And then we want to be mindful that when we are talking about breastfeeding rates or duration, there's a possibility that sometimes this language can inadvertently put the onus for change on the most vulnerable portion of this equation, which is the breastfeeding dyad. And so we want to focus specifically on the systems today. And then finally, that word resilience, particularly RSV season, working in a hospital, I see repeatedly that resilience is a factor in health outcomes, and we know that breastfeeding is one of the most important factors to change that. All right, and last slide. Next slide. And then your local health department may have additional data as fine as by zip code and as divided by race as well. And so this is a helpful starting point to inform your strategy. All right, next slide. So today we're going to look at systemic enhancements that were outlined in the Breastfeeding Friendly Pediatric Office clinical report in 2017. And I think that I have missed introducing us specifically. So we'll just quickly take a moment to catch up here. I'm Janet Wasilish Velasco. I'm a MedPeds hospitalist, and I'm at Dayton Children's Hospital. Julie.
Hi, I'm Julie Ware. I'm from Cincinnati Children's, and I work in the Center for Breastfeeding Medicine.
Hi, I'm Lydia Furman. I'm a general pediatrician. I'm at Rainbow Babies in Cleveland.
Hi, I'm Vanessa Shanks. I am a neonatologist, and I'm at Nationwide Children's Hospital in Columbus.
All right, so I think we're caught up now. Next slide. The next slide shows us a graphic of what a cohesive practice with policies at every step of the visit might look like, supporting families as they move through their feeding journey. And so this article outlines 19 or so recommendations to support our families. And undoubtedly, many of you have policies already, but this is kind of a nice checklist to look for areas to update. Next slide. So the first recommendation is to have a written policy, write it down so that everyone is working off of the same page. Next slide. Throughout the talk today, we're going to be referring to the Academy of Breastfeeding Medicine, which is an international organization of physicians who have developed over 40 protocols and position statements for best practices in breastfeeding care. For special clinical situations, there are very detailed outlines on many topics. Next slide. And for those of you who may be working in other settings besides the outpatient office, I want to also make you aware of ABM protocol number 35, which has guidelines for developing policy recommendations in special care environments. Next slide. I'll turn it over to Vanessa now.
So as Janet said, having a policy is very important. It's also important to have trained staff to help carry out that policy, which brings us to the second recommendation. We need to train staff in the skills that are necessary to support breastfeeding. It's important for all staff to have a basic understanding and supportive attitude about breastfeeding, not just the practitioners and the nurses, but also the PCAs, the medical assistants, and even those that are manning the front desk. This doesn't mean we're looking for everyone to become lactation consultants, of course. There are different levels of training that are available, some of which are listed here. An IBCLC is probably the most well-known, but it involves extensive education and experience, and it really might not be feasible for most pediatrician offices. Advanced lactation consultants and certified lactation counselors, these are also sufficient to handle most basic breastfeeding problems, and they require a lot less intense training, which makes them a really good option for a lot of outpatient clinics. Next slide. Some hospital systems have begun adopting a system that utilizes breastfeeding resource nurses. These are a group of nurses who have received specialized education through their own institution, but they did not complete the advanced lactation consultant or certified lactation counselor courses. There was a study that was evaluating one such course out of CHOP that found it empowered nurses to integrate evidence-based support into their daily routines by providing them knowledge about the evidence surrounding breastfeeding benefits and support. These nurses also became strong advocates and were more willing to go that extra mile because they understood the science behind it. So that information is really important. They also noted a ripple effect with these nurses extending their knowledge and support outside of the hospital and the medical field to their community and their friends. Next slide. Another study that looked at breastfeeding duration and its association with certain support practices at a variety of WIC sites. So we know that families with low socioeconomic status are particularly vulnerable to stopping breastfeeding sooner than is recommended. But this study found that WIC sites who had access to breastfeeding peer counselors and IBCLC, home visits by a lactation consultant or peer counselor, and the exclusion of providing formula in the first 30 days statistically improved any and exclusive breastfeeding at 2, 6, and 12 months, independently of each other. So you don't need to have all of these things. Even just having one had benefit. They also found that the ability of any staff member to provide breast pump education also significantly improved exclusive breastfeeding at 2, 6, and 12 months. So this is a really important step, making sure that staff is knowledgeable and supportive of breastfeeding efforts. Next slide. Taking it one step further, physicians and practitioners need to know the rare but true contraindications to breastfeeding. Medical schools and residency programs across the nation have historically struggled with providing sufficient breastfeeding education. But organizations like the AAP and the Academy of Breastfeeding Medicine have been working really hard to change that. Next slide. In 1995, there was a national survey of pediatricians, OBGYNs, and family medicine training programs that revealed that most programs offered lactation education through lectures or conference settings, with only half of them providing direct patient experience. Almost half of pediatric residents correctly answered questions about management of a breastfed jaundice, meaning that half did not. And about 3/4 did not know what to do about breastfeeding if the parent had a breast abscess. 5 years later, another survey found that almost half of pediatric program directors believed their own programs were inadequate or in need of improved breastfeeding education. Next slide. 10 years later, there was another survey of pediatric residents that showed a median of 9 hours of breastfeeding education spread over 3 years, with only 3 of those hours being direct patient care. So an average of 1 hour a year of direct patient care to learn breastfeeding medicine. I have spoken with countless pediatricians who tell me they are uncomfortable managing breastfeeding or watching a dyad breastfeed. And this is why most of us haven't been taught about it. A third of programs said that lack of attending physicians with sufficient knowledge to teach breastfeeding was a big barrier at their institution. So it's a cyclical problem, which is why this step is so very important. And I urge you to seek out independent learning resources, which we'll talk about in just a minute. Next slide. Knowledge about the true indications of breastfeeding. Historically, these have been very cut and dry, and I've listed a few of them here. You probably are familiar with these, but lately there has been a shift in medicine. It's becoming less and less paternalistic, and more emphasis is being placed on patient autonomy and family-centered care with shared decision-making between the parent and the provider. So what was once cut and dry has now become very gray. So how do providers advise families in some of these situations? Next slide. The most important piece to remember here is that parents are the ones who are making decisions for their children. And our role as pediatricians is to make sure that they have complete and accurate information in order to make those decisions. We need to be able to explain the risks and benefits of breastfeeding. They need to understand the difference between theoretical risks and proven risks, especially in lactation, where you can find large gaps in the literature. Breastfeeding medicine is a newer field, just like neonatology. We still have a lot of questions that haven't been answered yet, and a lot of questions that we want the answers to. Shared decision-making provides parents with the opportunity to be parents. And at my institution, we have seen a desire to breastfeed be a motivating factor for some parents to really rise to the occasion, particularly those who struggle with substance abuse. They tell us that breastfeeding helps to keep them focused on their sobriety. But it's also important to minimize risks. A parent with HIV who decides that they are going to breastfeed their child, despite our recommendation not to in the United States, needs extra support. Extra support to ensure that they are able to exclusively direct breastfeed to minimize the risk of transmission. If a parent shares that they plan to use someone else's milk to feed their baby, despite our recommendations not to, then it's important to teach them what questions they should ask about the donor and the donor's partner. And the Academy of Breastfeeding Medicine has a protocol for that. Shared decision-making can be really hard, but it's our role to make sure that they are informed decisions and that they're involving as little risk as possible. Next slide. So in order to have these conversations with families, we need to be educated. We need to know the information or where to get the information. And I've listed a handful here. These are all reputable resources, some of which are free, which is always nice. IABLE has a lot of good webinars, some of which are recorded and they're generally pretty cheap. Gold Lactation and Healthy Children's are both national organizations. The Academy of Breastfeeding Medicine has close to 40 evidence-based protocols, as Janet mentioned. They're freely accessible online. You don't need to be a member to access them. You can just put them into Google and they'll pop up. And then the AAP, of course, has great information for physicians and trainees as well. So as I said before, I really encourage you to look into some of these resources, increase your own education to be able to better support your patients and their families. Next slide. Recommendation number 4 is to introduce the subject of breastfeeding early using open-ended questions, again, to encourage the shared decision-making and the good conversations with families. Ideally, these conversations happen prenatally, which can sometimes be difficult as pediatricians. But if you care for other children in the family, or if you meet with parents prenatally who are looking for a pediatrician as first-time parents, then you may have an opportunity to have these discussions before the baby is born, which is really ideal. The 3 most common reasons parents choose to formula feed are the anticipation of pain that is believed to be associated with breastfeeding, the anticipated modifications to their current lifestyle, and not knowing anyone in their circle of family or friends who has ever breastfed. It's important to educate expecting parents that pain is not normal when you are breastfeeding or pumping. This is a very widespread myth that nipples have to toughen up or that the first couple of weeks just hurt. That is not true. Many parents also don't realize that the lifestyle modifications that come just from having a baby, regardless of the feeding method, they're not expecting that at all. So talking through some of these anticipated changes can be really helpful. And emphasizing the resources and support networks that are available in the community can help for those who don't personally know someone with breastfeeding experience. There are often a lot of resources out there, but parents just aren't aware of them or know how to access them. Research shows that women who received encouragement from their medical care provider were actually 4 times more likely to initiate lactation than those who did not receive encouragement. Studies also show that these conversations do not lead to feelings of guilt, which is often a reason medical personnel are hesitant to have these discussions, especially my nurses that I work with in the NICU. But parents want to have these discussions. They want to learn the facts so that they can make an informed decision about feeding their baby. Next slide. The 5th recommendation is to encourage mothers to use only human milk. This conversation flows really nicely with the previous one if they decide to breastfeed. As providers, it is really important that we only supplement babies when medically necessary. As a neonatologist, I often see babies that require supplementation to maintain hydration, appropriate glucose levels, but supplementing when it is not truly necessary can really undermine breastfeeding efforts. It can confirm the parental misconceptions about normal newborn behavior, making them think that they have insufficient supply, when that insufficient supply concern is actually pretty rare, but it's believed to be very common. It also results in the infant spending less time at the breast. That can result in poorly established supply. And then those misconceptions become a very real reality later. If supplementation is medically indicated, we encourage the use of expressed human milk if available. There are some newer studies that have been looking at the gut microbiome that have shown that even 1 bottle of formula can change the microbiome in the infant's gut. We don't yet know if this translates into a clinical difference for the child. That research is still forthcoming. But we do know that differences in the gut microbiome in infants has been seen in correlation with differences in obesity and atopy between formula-fed infants and breastfed infants. So it's very possible that there are going to be clinical significances that come out of this later research. So stay tuned. Next slide. Recommendation number 6 is to work with committees within your local hospital to implement breastfeeding-friendly care. I'm sure everyone is familiar with the baby-friendly designation that many hospitals strive for, but in Ohio, we're actually really lucky to have the First Steps program as well. The World Health Organization Code of Marketing and Breast Milk Substitutes has led to a great decrease in marketing products and free formula bags that were used to be widely distributed at birthing hospitals. So looking to further these efforts at your local delivery center can really help set families up for success as well. Next slide. And then once the baby is discharged home from the birthing hospital, it is crucially important to see them in the office around day of life 3 to 5, or within 24 to 48 hours after the hospital discharge, especially if the parent is breastfeeding. Breastfeeding can change rather dramatically within the first 4 to 5 days of life. There are many different physiologic processes that are occurring in the baby and the parent, and it's really important to assess these things early on. It's important to look at the baby's weight and any concerns for jaundice, as this tends to peak later in breastfed babies than in formula-fed babies. It's also a good time to assess any breastfeeding concerns that might have come up since leaving the birthing hospital. If their breasts are feeling more full as their milk volume increases, if they're having any pain with breastfeeding as the infant becomes more alert, if there are any identified risk factors that would prompt an earlier lactation referral. It's also a good time to assess the parent's mental health. Many parents who are struggling to establish breastfeeding or needing to use lactation tools like pumping or nipple shields, even temporarily, can find it very overwhelming without proper support. It's also a good time to manage expectations. It can take 4 to 6 weeks for breastfeeding to become established and become what most people envision that is supposed to happen right after birth. And those first 2 weeks can really be a bit of a shell shock for a lot of new parents who have not breastfed before. It's really important for them to know that this is normal baby behavior. It's normal parent feeling to feel overwhelmed, and that it's something that we expect to get better within a specified time period. And if we can get them past that first month, then things often become much more like what they originally envisioned. And now I will turn it over to Julie to discuss about returning to work.
Thanks, Vanessa. So now you've got them all breastfeeding well in your office, thanks to all of Vanessa's recommendations. So now we want to be sure to educate our mothers about the Patient Protection and Affordable Care Act. This is recommendation number 8. Break time for nursing mothers provides a reasonable break time for employees to express their milk and a place other than a bathroom shielded from view. As well, it covers access to breastfeeding support services and ability to obtain breast pumps through insurance. Next slide. Next slide. Yes, thanks. The USBC that Janet mentioned outlines this very nicely in that the 2010 law was really focused on hourly wage earners and some salaried employees, but it doesn't cover everyone. And it does provide the reasonable amount of time other than a bathroom, as mentioned. Next slide. So this is what we want to highlight today, that 1 in 4 mothers are not covered by that current break time for nursing mothers. And so we'd really love for all of you to support the PUMP Act for nursing mothers, which is providing urgent maternal protections. It did pass the House in a bipartisan way. And it is hopefully coming up after the August recess into the Senate. And if you can contact your senators to support the PUMP Act, that would be wonderful, because this is a lot of families who are not covered by the current law. And our teachers are one group that sometimes fall through the cracks when they go back to work. And we certainly want to support all families when they go back to work. Next slide. So recommendation number 9 is where the pediatrician also comes into view. We are going to be seeing these mothers and we're going to provide them anticipatory guidance because we're seeing them at their various life stages. So they may not know how to express and store their milk. So we have guidelines from CDC about how to do that. This little graphic can be made into a magnet or a handout to give to your families. And then the business case for breastfeeding has been developed by HRSA for employers to help families with breastfeeding support. And I just have a picture here of one of my patients who was a Memphis City police officer who was able to pump her entire first year of life. And she gave permission for me to show her picture as an inspiration to others who think, well, I can't do that when I go back to work. So she was on the beat and going into the precinct to pump her milk for her baby's first year of life. So she is an inspiration indeed. Next slide. The Office of Women's Health has other resources for employers. So there are a lot of examples of ways to help mothers when they go back to work. And next slide. My favorite is the agricultural support. So you can see that on the right, there's a little video of the pop-up tent that goes in an agricultural area for moms who are out in the field but need to pump their milk. So this is a wonderful resource that you can share with families who might say, this is my job, so I won't be able to continue, but you can say, aha, let me try to help you. And next slide. Ohio has a whole toolkit on how to help in the workplace. And we're very thankful for this in Ohio. And I want to highlight on the right, you see this sample letter from the provider to the employer. So if you had a mother, a family who was concerned about going back to work and whether these accommodations would be provided, you can use this letter as a template. And it often is very successful when it comes from the physician. And it is on the last page of the outreach guide of the link you have there. Next slide. So just one final thing on the workplace, ODH has just launched the Breastfeeding Friendly Workplace Award, and I see that we have 43 participants here. We all work somewhere. Wouldn't it be wonderful if we all applied for our workplace to be designated as a breastfeeding friendly workplace? There is a simple application link. The toolkit link is there. And then we can also share this with our families who may need help with becoming a breastfeeding friendly workplace. And all 4 of us as chapter coordinators would love to help you with this. Next slide. So recommendation number 10. We're going to get ready for those breastfeeding babies. As Janet told you, almost 84% of moms start breastfeeding. We want our front office staff ready to engage the families and let them know that when the baby's ready to feed, we want to scoot them into a room so the provider can watch that breastfeeding. Next slide. We want to also provide appropriate educational resources. So we talked with Vanessa a lot about educating the family, staff and the physicians, but we want to educate our families as well. And I was thinking about how much we have to talk to the families about. It's quite overwhelming, I know, but there are a lot of resources that are available. So I'm going to highlight some of them that are noted here for you. On the right, you see the breastfeeding benefits poster that was developed by ACOG, and it's got benefits for mom and benefits for baby. And this is something that can be downloaded and hung up as a poster or given as a handout. And next slide. When we talk about benefits, I just wanted to add this in for you that we want families to know that we now have good data saying that breastfeeding does reduce infant mortality or is associated with a reduction in infant mortality. The picture on the left is actually from Memphis, where I used to work in 2005, and the infant mortality was so bad there. The babies were buried in a community grave. It has improved over time, thankfully, there. But infant mortality is horrifying and devastating to families and any pediatrician who's ever experienced it with a family. So a recent study of over 3 million US infants found breastfeeding initiation, so any breastfeeding, reduced the risk of post-perinatal infant death 7 to 364 days by 26%. And this is something that we can really share with families as a powerful reason to think about breastfeeding. Next slide. So the cueing, that's important for parents to know in those early days that Vanessa talked about, is also available, a really nice infographic that you see here at First Steps. And all the links are in this presentation, so you'll be able to go back to it. Next slide. Positioning. Positioning can take care of some of that pain that Vanessa was talking about. And these handouts are available at It's Only Natural in the Office of Women's Health. Next slide. And some of our favorite resources are the First Droplets videos created by Jane Morton, and the Your Guide to Breastfeeding, also by Office of Women's Health, that can be downloaded for families or ordered for you to pass out in your office. Next slide. And then the favorite of all favorite, which some of the practices I've spoken to have put on their website, is this Global Health Media, How to Attach Your Baby at the Breast, which really creates some light bulb moments of, oh, okay, and this is why it won't hurt, or this is why it was hurting. So some of these resources may really help you to educate your families. Next slide. And families need to know how to know that breastfeeding is going well. These are just some examples from Cincinnati, Tennessee, and one of our local hospitals of handouts that can be given to families to highlight what to expect in those first days and how to know breastfeeding is going well and when to ask for help. Next slide. And then recommendation number 12 is to allow and encourage breastfeeding in the waiting room. So we've already alerted our front desk to bring them to a room if it's time to breastfeed for their appointment. But if they want to breastfeed in the waiting room, we don't want to discourage that. We want to highlight breastfeeding as normal. And some of these posters can be hung in your office. And an example of one of them that's available to you is the Obesity Prevention Begins with Breastfeeding. The AAP section on breastfeeding has some of these available and provided the SurveyMonkey link there, that if you do that within the next 2 weeks, you will get a poster in the mail directly to you. Next slide. And it is the law that we protect a woman's right to breastfeed anywhere she has the right to be, and every state has a similar law. So it's important for us to help families understand that. Next slide. And then recommendation number 13, Vanessa touched on this a little bit for the hospital situation, but in the outpatient setting as well, we want to eliminate the practice of distribution of free formula in accordance with the Code of Marketing. And this is especially important not to accept gifts like supplies, pens, coffee mugs, because then in turn, we become marketers of infant formula. And this really does undermine breastfeeding and has been documented. Next slide. There's a new WHO UNICEF study that highlights that we as health professionals have this personal access to our families and this trusted role. And we are seen as marketers of infant formula. We are actually convincing them of the need for formula. And it's quite a important thing for us to think about in our practices. And I think now I'm handing it over to Lydia.
Okay, thank you guys very much. We're in the home stretch. So recommendation number 14 relates to staff training. Asks you to train staff to follow telephone triage protocols to address breastfeeding concerns and problems. And we have a couple of awesome resources for you. Next slide, please. So Maya Bunik, who's an AAP section on breastfeeding member and leader, has a fantastic telephone triage and advice book. The most recent edition is just out, and you can purchase this through the AAP shop. The other resource that we would love you to be aware of and have not just staff and physicians use it, but it's really intended for patients and families. We're very, very fortunate in Ohio that the Ohio Department of Health has been able to sponsor and contract so that we have a free 24/7 breastfeeding hotline. You can either call or you are able to text. It is picked up live by a breastfeeding specialist, if a CLC or an IBCLC, and there's always an IBCLC who's the gold standard for breastfeeding information available. So that's picked up live, and many of their calls come in after hours. Next slide, please. Recommendation number 15 is to acquire or maintain a list of community resources and become knowledgeable about referral. The best place to start is always right in your own home, so in your own office. And if there are a couple of mothers that whose children you care for who are have met their breastfeeding goals and feel empowered, it would be wonderful if they could begin a breastfeeding support group in your own office. Then you become part of the promotion and part of the support. You're giving space, you're giving voice. So we encourage you to consider that. In your own area, you are likely to have a WIC office. You are likely to have Lactation League sections, as well as possibly baby cafes. And these are all national, and obviously WIC is federally funded and state run, but these are all national organizations, and these are support groups where parents can find other parents and get that support that they need. Your best resource for resources is the OBA, Ohio Breastfeeding Alliance website, which enables you actually to participate and upload breastfeeding resources of yours or of your community. And that is a live link there where resources can be uploaded or edited. Next slide, please. This is a screenshot of the OBA resource list. This is way zoomed out. So when you zoom in to your own area, hopefully you will find some great resources. Just re-advertising the incredible breastfeeding hotline, but to emphasize that the breastfeeding hotline refers parents to local resources. So it's especially important to make sure those resources best you know are updated in your area. Next slide, please. And then finally, almost finally on resources, this comes from Dr. Ware's group in Southwestern Ohio. They have their own breastfeeding coalition. So you can look for one in your area. You can join forces with a couple of colleagues and begin one. They have a website with tons of information. Next slide, please. That is interactive. And next slide, please. So that is a great resource if you're down in that area, and if not, consider beginning something like that. And then finally, we want you to be aware of the probably best place to go for either you or the patients and families to find out if medications are breastfeeding compatible. Drugs and Lactation database, LactMed, is available free online. It is evidence-based. It is very simple to use. You can Google it to get to it or use that link. You type in the medication and you learn. And I think it can empower patients and patients' mothers and you yourself also. Next slide, please. So recommendation number 16 regards frenulum and tongue tie clipping. So frenulum clipping has become a popular practice, which may improve infant latch and the effectiveness of breastfeeding and milk transfer. Work closely with local lactation consultants or specialists to determine if frenotomy is appropriate. Next slide, please. And I think what I've put in red there is really the key message. This is a very controversial topic, as you're likely aware. We encourage you to work with IBCLC or lactation specialist whom you trust and who is able to do shared decision-making with the family about the appropriateness of the clipping, and also importantly, to provide support both before and after, because clipping a tongue tie alone is rarely, quote, curative for all breastfeeding problems or for latch problems. We encourage you to avoid referring to ENTs, dentists, chiropractors who may advertise this procedure as sort of a one and done curative treatment or require repeated visits, which are not covered by insurance or are out of pocket. Really encourage you that breastfeeding is usually not helped by frenotomy alone, and lactation support before, during, and after is really critical. The Academy of Breastfeeding Medicine, I know we keep referring to them, but their resources are wonderful. It's a very dedicated organization, has a statement on tongue tie that can be very helpful to you if you want more information. Next slide, please. Recommendation number 17 is to collaborate with the obstetrical community and your obstetrical colleagues, because mothers do decide how they're going to feed their baby, if not during pregnancy, often before that time. Next slide, please. So I want to come back to the wonderful resources that you just heard about from Ohio First Steps, which is on the Ohio Hospital Association website. So First Steps promotes the adoption of breastfeeding supportive practices in birthing hospitals. The resources are phenomenal, and they are free, and they can be personalized to the hospital or to the individual obstetrician. Secondly, we encourage you to take a look at ACOG's statements on breastfeeding, which are excellent and comprehensive. And I think that way you'll be able to really communicate with your OB colleagues in a very positive way to share the support, prenatal support for breastfeeding. Next slide, please. Recommendation number 18 is to provide support and education to local childcare centers on the importance of breastfeeding and handling breast milk. Next slide, please. And here again, we just want to emphasize to you that the Ohio Department of Health is a fantastic breastfeeding partner. This is yet another program from ODH. So there is a breastfeeding designation program for childcare centers, and this is their logo, and there's an application process. So we encourage you to encourage all nearby childcare centers to become recognized as breastfeeding supportive by the Ohio Department of Health Childcare Program. And you can suggest to parents that this is a great thing that they can do, is ask their own childcare center to become designated. Next slide, please. The steps are right here online. And yes, somebody asked in the chat, will you get these slides? Yes, you will get these slides. So there is training, which is online and free through Ohio Train. There's more information about the award on ODH's website. And then there are applications, which are straightforward, easy to use in REDCap, and a model policy is available to adopt. So I think that ODH has worked hard and done a really beautiful job with this. So just encouraging childcare centers to participate. Next slide, please. And then finally, recommendation number 19, the last one, is to monitor breastfeeding initiation and duration rates in your own practice and be able to know where the rates are available for state and nationally. Next slide, please. So kind of circling back to where Janet began us, I believe you now know where you can find United States national information. The CDC website is likely the most reliable and best source. And the Ohio Department of Health for statewide rates has beautiful information available. We really encourage you to consider collecting rates in your own practice. I'm doing this in our practice. I know it is not the easiest thing, in that it depends how user-friendly your electronic medical record is. But doing a snapshot, doing 1 week out of each month, even if your EMR can't sweep the data for you, is potentially very feasible. And then you can review it with your staff, either monthly or quarterly. And then you can see, are we making progress? Are we heading in the right direction? And Dr. Ware pointed out to me that you can actually create your own quality improvement initiative and potentially get MOC Part 4 credit. So I think this could be a wraparound. It helps families, it helps staff, and it can help you also. Next slide, please. And the beautiful thing about all these recommendations that we've been discussing with you is that they are not only evidence-based, but there is evidence that they work. So this beautiful little article from just last year, actually, this is a practice that adopted not all 19 recommendations, but about a half dozen of them. And I've listed them there. I don't want to read them to you, in their own quality improvement project. So, and they gathered data as is recommended in recommendation number 19, and they found that they had a statistically significant increase in initiation rates and rates of breastfeeding at 1 month, and an increase, though it was not statistically significant, at the 2 and 4 month visits. So yeah, this works, and that's the amazing thing about it. One more slide, please. This is our contact information, and we're all happy to talk with you, happy to help you. When I don't know something, I communicate with Vanessa, Julie, and Janet. So we are definitely a team, and we're eager to help you and support you. I'm going to turn it back to you, Julie, for just the sort of wrap up.
Thanks, Lydia. Next slide. So we want to thank our Ohio section on breastfeeding members. There are quite a few in Ohio, and we've highlighted them here. And next slide, those of you who aren't already a section member, we'd love to have you. And this is the link of how to join us at the section on breastfeeding. We have a lively, but not too lively listserv where you can talk with people all over the United States about what you're experiencing in your practice. And next slide. We would also love to see you in Anaheim at the NCE. And next slide, we will have a section session, and we're going to cover topics like the LGBTQ community, paid family leave, refugee populations and disasters, perinatal mood disorders, and of course, our policy statement. And then next slide, you will see in the big NCE, Lydia mentioned ankyloglossia. Well, there will be a hot topic on that, as well as breastfeeding essentials. If you want to get into the real nitty gritty, how to do it 101, and then again, our highlight of the policy statement. So lots of opportunities there. Next slide. We've talked a lot about ABM, and we're having an in-person meeting this year in Baltimore, and love to have any of you join us there if you want to hear some cutting edge research. It's always a very wonderful meeting. And next slide. Tomorrow night, our lead authors of our new policy statement, Dr. Meek and Dr. Noble, will be with our chair, Dr. Lori Feldman-Winter, and go over the new policy statement. So we'd love for you to join us for that, 7 to 8 p.m. Central tomorrow. And next slide. And we wanted to just end up this way. Janet started us off with the data and showed us the disparities in breastfeeding. And we talked about how there's things we can do within our practice to help families. And so this was a quote from the World Alliance for Breastfeeding Action from 2018, World Breastfeeding Week. And breastfeeding is a universal solution that levels the playing field, giving everyone a fair start in life. In a world filled with inequality, crises, and poverty, breastfeeding is the foundation of lifelong good health for babies and mothers. And we just thank you very much for joining us today, and we're happy to answer any questions.
Thank you all so much. That was wonderful information, and so much information in less than an hour. So that was great. I know there were a few questions in the chat box, and I think that some of them were answered as we went. All of them were answered as we went. So thank you all for monitoring that as we went through the presentation. Are there any other questions that you all would like answered? That we have a few minutes left, so.
I just wanted to add to, there was a question about starting cereal at 4 months. And I just want to add that some pediatricians, we see babies at 2 months, 4 months, and 6 months. We have a specific schedule. So it takes a little extra effort when you're at that 4-month visit to make sure the parent understands that the reason you're talking about cereal is not because you encourage them to start it tomorrow, but because you encourage them to start it in a month and a half or so. So that little extra qualifier sometimes may get missed. So I wonder if that's sometimes why parents start cereal a bit earlier. So just one thought. I don't know if the others of you have any. Because I definitely, we definitely agree that exclusive breastfeeding through 6 months is what's recommended and is optimal for infant health. Many times that 6-month visit is not before 6 months, it's afterwards. So I think a lot of us do talk about starting solids at 4 months, not with the intent of sabotaging exclusive breastfeeding through 6 months, but from a pragmatic point of view.
Great, thank you. Are there any other last minute questions? Wonderful. Well, thank you all so much for presenting. This was a wonderful presentation. We're so glad that you all could be with us. And just a few wrapping up items. The Ohio AAP Parenting at Mealtime and Playtime program also has some breastfeeding resources available. And our preventative health program will have resources available on the website, as well as this recording and the slides. And then the CME survey will be sent out on tomorrow. And if you have any questions, please let me know. And I think there was one last question in the chat box.
Yeah, I was trying to respond to that quickly in the chat box. So
great.
after 6 months, breast milk alone doesn't meet the baby's needs for iron, protein, and calories. So certainly continued breastfeeding is very important, as well as adding vitamin D drops and a source of iron. But at that point, complementary foods are appropriate and needed for the baby's nutritional status and growth.
Perfect. Great. Well, thank you everyone for all the great questions. And please look for an email from me tomorrow. And thank you to our presenters in the Ohio Department of Health again. And we will see you all at our next training on vaping. Have a wonderful rest of your week, and hopefully it won't rain.
Thanks so much, Alex, for all your support.
Yeah, thank you all so much. I appreciate it. This is wonderful.
Thank you.
Thank you.